The thyroid gland. It's normally not palpable in the neck. If it is palpable, then that likely means it is enlarged. Let's review what are the functions of your thyroid gland. What does it do? It it's a endocrine gland, produces three hormones: thyroxine, triiodothyronine, and calcitonin. The first two, T4 and T3, are your controllers of metabolism. High T3, T4 means you have high metabolism. Low T3, T4 means you have low metabolism. Calcitonin is a hormone needed in order to decrease calcium levels in the blood. They decrease serum calcium. How does it do it? It causes calcium to be deposited in the bone. It is obviously secreted during periods of hypercalcemia in order to reduce serum calcium levels. Any question on the three hormones? Alrighty. Let's go now to the two problems. Let's go straight to the, let's review briefly how we make T3, T4. So the thyroid hormones are made using iodine. So what are the sources of iodine? Okay, it's mostly shellfish, right? Or since not all of us have access to seafood, let's say you live and work in the mountains, for instance, far away from the shore, and let's say it's not very accessible, so you have little access to seafood. That's why what did the government mandate? That all salt sold in supermarkets contain what? Iodine. All right. So that's to make sure everybody has adequate intake of iodine. So think of iodine as a raw material. So with iodine, the thyroid glands are able to make T3 and T4. The control, however, is regulated by the pituitary gland, it being the master gland. So it constantly monitors levels of T3, T4 in the blood and responds accordingly. So if there is little T3, T4 circulating in the bloodstream, the pituitary gland releases a thyroid stimulating hormone, which will cause or stimulate the thyroid glands to make more of the T3, T4. Whereas if the other problem exists, let's say you have too much T3, T4, then the pituitary gland will cause the restriction of the release of TSH, thereby decreasing stimulation of the thyroid glands. Any questions up to this point? All right, let's go now to the two problems. And here are the purposes again. We already described T3, T4, and calcitonin function. All right, the first problem is hypothyroidism. There are two forms of the disease. We have a primary and secondary. Primary means it's an autoimmune problem. What is the nature of every autoimmune disease? Okay, so it is caused by our own antibodies, our own immune system attacking our body, attacking certain organs or tissues. So in this particular case, the patient has an autoimmune disorder destroying the thyroid gland. It is known as Hashimoto's disease or autoimmune thyroiditis. Because it's autoimmune, do we know the cause? What's the cause? We don't know why our body produces autoantibodies attacking our gland or our organs. So we don't know. So we have to just treat it symptomatically, right? So as early as now, the management will be to replace the hormone. Okay, so the patient has not enough T3, T4, meaning if it's Hashimoto's disease, that means the patient's thyroid gland were destroyed by your own antibodies, therefore is unable to produce T3 and T4. So you can eat gallons of iodine, it would be useless because the thyroid glands cannot make T3 and T4. You follow so far? Okay, so that is for Hashimoto's. However, there is a secondary form which is caused by treating the other problem. Say you have hyperthyroidism, meaning you have an overactive thyroid gland resulting in high levels of T3, T4. When you treat that problem, it will result in hypothyroidism. That's why we call it secondary hypothyroidism. But regardless if it's primary or secondary, the treatment really is the same. The patient will have to take thyroid hormone replacements for life. However, the diagnosis will be different and the findings will be different. For example, in T3, T4, low levels of T3, T4 in Hashimoto's disease, what's the problem again in Hashimoto's? Okay, autoimmune, and therefore there is destruction of the thyroid gland. Now, what will the pituitary gland do again in response to T3 and T4 levels being low? It will increase TSH. So therefore, in Hashimoto's thyroiditis, Hashimoto disease, we will see high TSH, however, low T3 and T4. In secondary hypothyroidism, what's the cause again? Treatment of hyperthyroidism, and then now the patient becomes hypo, correct? All right. The TSH, no, sorry. There's a third type wherein it is caused by a malfunction of the pituitary gland, meaning the problem isn't with the thyroid gland. The problem is with the pituitary gland. The pituitary gland is ineffective, meaning you suffer from hypopituitarism. You follow? Okay, so that's the third type. So in hypopituitarism, what happens to TSH production? It decreases. Therefore, you have low levels of TSH, correct? That results in what levels of T3, T4? Low levels of T3, T4. What about if we have another problem, which is hyperactivity of your pituitary gland, meaning you have hyperpituitarism, in which case your pituitary gland produces high levels of TSH. What will happen to your T3, T4? Also elevated. You see the difference? Okay, so the difference lies in the laboratory testing. So when you see your patient's test results, because again, the doctor is supposed to explain the diagnosis. However, if you're diagnosed with something lifelong like this, are you really receptive to the teaching at the time that you were given the diagnosis? No, because you're thinking about the change in your lifestyle now. So your life will change. Okay, gonna have to be taking precautions. You're gonna have to learn about signs and symptoms and how to manage the disease. So did you experience some loss here? Some grief? Yes, you did. So therefore, are you in the best mind to receive the teaching? So when the time that you are ready, who is there at the bedside? The nurse. So you still need to know how to explain the diagnosis. The term myxedema mentioned here is actually a severe form of hypothyroidism. Hypothyroidism per se is not life-threatening. However, myxedema is like severe form of hypothyroidism is life-threatening. Okay, we'll look at manifestations as well as management of myxedema a little bit later. So here again is the summary of your causes, chart 45-3. So they belong to either primary, secondary, or a pituitary problem leading to hypothyroidism. So the RAI 131 mentioned in this chart, this radioactive iodine 131, is a method of treating hyperthyroidism using radiation. So this is the radiation used to treat hyperthyroidism. Yeah, so anything radioactive will do what to body tissues? Destroy it, okay? Kill it, just like cancer. Right, manifestations. So if T3, T4 controls your metabolism, controls your metabolic rate, what will happen to your metabolic rate when you don't have enough T3, T4? Okay, so think of the slowest, slow everything. Okay, so cognitive function is slow, heart function, lung, including the diaphragm, GI, genitourinary, muscular, everything is slow. Okay, so what will a patient with hypothyroidism look like? Okay, so we will see lack of activity, lack of energy. So they'll have fatigue, lethargy, weight gain, even if you don't eat. Let's say you eat only one cracker at the whole day, the patient will continue to gain weight anyway. Cold intolerance, dry skin. There's also hair loss. We have a picture here, figure right here. So this is what a hypothyroid patient will look like. I should specify an untreated hypothyroid patient. Okay. So once this patient, of course, is treated and then we arrive at the correct dose, of course, these manifestations improve or go away. Yes, sir. Slow metabolism, meaning plus it's stressful, correct? So cortisol will be increased, and that's what will cause the retention of sugar and fat, meaning your metabolic activity is now abnormal, meaning um, it's not going to correctly metabolize what you're eating, and then everything just goes to storage and fat. So that's what causes the retention. So there's fluid retention, there is increased fat deposition as a result. There's just simply no energy to carry out any activity. You've probably seen some of these patients on the subway that have you seen someone with a tongue, their tongue protruding out, like they're sitting like this, apathetic looking, no expression, and then the tongue like this, and they're kind of heavy set. So that's myxedema. That can be life-threatening. So the few people that you see that, those are obviously either they're untreated or never diagnosed. Let's say a homeless guy who don't have health care. So they go on for years, decades without any treatment. Then next thing we know, they're in respiratory arrest, they're unconscious, they're in shock, basically. So these are head to toe, starting from mental function. Okay, so let's say you have hypothyroidism without treatment, you cannot learn anything, right? You'll just be sleepy all the time. So there's constipation and edema. So those are your manifestations. In mixed edema, like I mentioned earlier, this is now severe hypothyroidism. This can be life-threatening because cardiac function is impaired here. The patient will have really low blood pressure, heart rate, although there's supposed to be a reflex tachycardia because of low cardiac output. Here, though, the patient will have bradycardia. There's just simply no energy, not even enough energy for the heart to properly function. Mixed edema also can be precipitated by stress. Let's say the patient undergoes surgery, that can result in acute mixed edema. Yes, I can't hear you. Yes, very good question. What type of arrhythmia though? Tachy or Brady arrhythmia? It would be Brady because the heart function is just decreased. Now, the mixed edema coma, which is the end result, coma here is actually a late sign, meaning when they're in coma already, they're most likely going to die already, right? So do you want to see early or later signs of mixed edema? Okay, we'd rather catch them early. Let's go to management. Pretty simple. So you don't have T3, T4, so what do? We give it to you, okay? So it's available by mouth or IV because, of course, if you're conscious, we give it by mouth, correct? So if you're in mixed edema already, wherein your blood pressure's low, heart rate's low, mental status, you're lethargic, can you take anything by mouth? No, so there is an IV form of levothyroxine, which we will give intravenously during mixed edema. Or in times of, let's say you're NPO for a procedure. Can we shove down the levothyroxine down your throat? Okay, no. So that's another exception. So if your patient is NPO for anything, can we stop the levothyroxine? Do we have that option? No, because we can't give it to you because you're NPO. No, because does the patient need this every day? You need it every day for the rest of your life, so you can't go without it. Are we clear? So what is one of your teachings for these patients? Let's say they got COVID, they got the flu. They're so sick, they can't take anything by mouth. What's your instruction? Do we ground it and, put it in a spoon and a lighter and then inject it? Okay, go to the emergency room, right? You don't know about the spoon and the lighter? I'll hang out with me later. Okay, with with levothyroxine, the dosing here, let's say you're just newly diagnosed, correct? We have no idea how a patient will react to synthetic thyroid hormones. So the dosing here will be carefully started at the lowest dose possible, right? And then the principle of increasing the dose is we start low and go slow. Okay, again, start low, go slow. Now, it's important that the patient understands this because the increasing in the dose will take months at a time. the doctor will not increase the dose weekly or bi-weekly. They do it several months at a time because again, the danger is we have no idea how the patient reacts to every change in the dosing. So we have to monitor the patient several months at a time with every dose. Then we increase or decrease depending on their T3, their serum T3, T4 levels. Again, because we don't know exactly how their body reacts to it. Because remember, what happens to drug metabolism as well? When you have hypothyroidism, it's also decreased. So that affects the therapy, right? So make sure the patient understands that, oh, I'm still gaining weight. When is this going to change? I was promised this will improve. Okay, so let's say this patient is 22 years old, diagnosed with hypothyroidism. Okay, and they're fat and they're slow. They're tired all the time, and they want to be sexy and go out with their friends. So it can be frustrating, correct? So make sure the patient understands why the therapy is like this. Okay, why they have to be patient with the dose changes. And here are a few considerations. So here the statement says older adults generally require a lower dose because what's the metabolic need of the older adult is decreased and anyway to begin with, right? Because they don't require that much. So they start even lower and then the change will also be even slower. So here is our number one concern, prevention of cardiac dysfunction. We may accidentally give too much of the hormone, resulting in possible cardiac arrest, or severe hypertension or tachycardia, for instance, resulting in harm or death to the patient. So this is the number one concern with regards to levothyroxine dosing. All right, are we clear? So don't tell the patient, don't double dose, right? Don't change the dose on your own. Okay, it's very dangerous if you do that. Here are a few considerations to consider. Now, most patients affected with Hashimoto's are females. The onset for Hashimoto's is, although the peak is around 40, meaning this is more adult, middle age onset. However, there are cases wherein we have young people developing hypothyroidism. So in that case, if they take, let's say, medications, for instance, birth control pills, okay, so that will affect metabolism of those drugs as well. Okay, make sure they check with their doctor before they take anything new, okay, or especially over the counter. Now, let's look at this paragraph here. Because of the decreased metabolism, and again, consider also drug metabolism is also decreased. These patients are very sensitive to CNS depressants. So benzodiazepines, for instance, sedatives, hypnotics, opioids. Okay, they're very sensitive to these CNS depressants. So be cautious whenever you give it because let's say this patient is confused, right? A patient with hypothyroidism and then have acute psychosis. Okay, you know what I'm saying? Oh, they went crazy. Okay, and then you're ordered to give, let's say, Haldol, okay, to sedate the patient to stop the behavior, and then you didn't get immediate effects. Okay, the patient is still thrashing around, punching everybody. So be careful if you think about, okay, I want to ask the doctor for a second dose. Okay, it's because the first dose didn't work. Maybe it didn't work because the drug was just just decreased there's just decreased drug metabolism. That's why it's not working yet, meaning it takes time for it to kick in. So maybe later when it does kick in, now your patient has overdosed on the benzodiazepine or those CNS depressants you've given. Are we clear? All right. Sorry. Exactly right. There may be toxic levels of the drug already. Okay, so they're very high risk for drug toxicity. Yeah, liver drug metabolism is slow. Exactly. And then renal excretion is also decreased. Supportive therapy would be, what would be the effect? Let's say again, let's say, Jennifer, you have hypothyroidism at your age. Okay, so let's say you gain 300 pounds. All right. So what will you feel? How will you feel? None of your clothes fit anymore.
But I want to wait to get to the point.
No, let's say you one thing led to another, right? Now, first you were diagnosed, and then the doctor wouldn't change the dosing. Then now your boyfriend left you, that made you depressed, right? Then you started eating even more, right? Yeah. And then before you know it, you woke up one day and then, whoa, what is this? Okay, there's 300 pounds on you already. Okay, so what I mean is we also treat the other symptoms that will result. And again, all the other symptoms, meaning these patients have cold intolerance, right? They have fatigue, they have what else? Constipation. So we treat all those symptoms of the disease, right? Until they improve over time, right? Can these patients also develop heart failure? Yes. So here's your summary for taking care. So we got several problems here, from impaired breathing pattern. Okay, this is referring to respiratory arrest, meaning is the diaphragm a muscle?
Yes.
Can it also be weakened by hypothyroidism? Yes. Although this only occurs in myxedema. I mean, we don't see this in hypothyroid patients when they develop myxedema. So yes, they'll have dyspnea and respiratory depression. Right? I won't read it for you. I'll let you read each problem and the plan. Okay, so this one's for cardiac function. Okay, and then it'll talk about skin care, and then constipation, activity intolerance, etc. Any question on hypothyroidism? All right, let's go now to hyper. If you have autoimmune disease, which is called Hashimoto's in hypo, then you also have an autoimmune form in hyper. Hyper is the opposite. This time you have an overactive thyroid gland producing so much T3 and T4. It also has a autoimmune form, which is called Graves' disease. I had a nursing school classmate. I had a really huge crush on her. And I noticed that I suspected she had hyperthyroidism because the age of onset for this, the peak is around 20, okay, between 20 and 40, whereas hypo was 40 and above, right? So this one is younger onset. And so she had it, and then she had the symptoms also, wherein her eyeballs were getting bigger, enlarged. And then she disappeared. I don't know where she went. On my third year of BSN, I didn't see her anymore. We could have been a couple. So Graves' disease is the autoimmune form. There is, of course, a secondary form, meaning when we treat hypothyroidism, could we possibly cause hyperthyroidism? Yes, if you took too much of the hormone. Clear? All right. So manifestations will be opposite what we saw in hypo. So here's another figure. So they usually have a startled look. Now, there are two reasons for the eye looking like it's bulging here. Now, one is the eyelid retracts because that's what you don't see here, correct? See that the patient here does not have eyelids. So the eyelids retracted, giving you the appearance of a startled look. Plus, there's also fat deposit behind the eyeball. They call that thyroid eye disease or TED. And we have treatment for that. We have specific treatment for the thyroid eye disease to decrease the fat deposit behind the eyeball. That's the least of the patient's problems though. Although, yes, it's a problem because can this cause dry eyes if you can't blink? Yeah, because again, the eyelids retract. You can't blink. You can't moisten your eyes, correct? So we'll have to give them eye drops to moisten the eyeball. And at night, we can actually tape the eyelid shut. Okay, we can put paper tape, just to shut it so that they can sleep comfortably. Now, let's talk briefly about goiter. Goiter is the enlargement of the thyroid gland. Now, yes, most people with hyperthyroidism, especially Graves' disease, have an enlarged thyroid gland. We call it goiter. However, some hypothyroid patients also have goiter. So therefore, is goiter a distinct manifestation of hyperthyroidism? No, because it's also present in some hypothyroid patients. Now, the reason for the the goiter formation in hypothyroidism is, remember in Hashimoto's disease, what is the TSH level of those patients? Very high, correct? So it forces the thyroid gland to become hyperactive. However, even if the blood flow and activity of the thyroid gland increases, causing enlargement, does that mean it will increase T3 and T4 production? No, because the thyroid gland in Hashimoto's is defective. You understand? All right. And the principle really in the enlargement is just like the penis. How does the penis enlarge? No, it's blood flow, right? It's increased blood flow to the penis, right? That's why Viagra works by, what's the warning for Viagra? Don't take Viagra if you have, if you have experienced a sudden drop in blood pressure. If you take nitrates, because nitrates and Viagra have the same effect. They are all vasodilators. So the cause of the enlargement here is really increased blood flow to the thyroid glands. That's why they enlarge. Are we clear? Okay, so any hyperactivity of the thyroid gland or any organ in the body will increase its size. Okay. So there's tachycardia, increased blood pressure, increased appetite. However, opposite hypothyroidism, these patients, no matter how much they eat, they will lose weight. Meaning there's not enough time in the day for them to eat in order to sustain their metabolic needs. Okay, so their metabolic activity is so high that they literally eat themselves up. They burn through fat, they burn through muscle, right? So that's why they lose weight. Isn't that amazing? Would you like this? No, you don't want this. Okay, this is life-threatening. Right? So they're always sweaty, they're always hot in the middle of winter. They'll be wearing tank tops or nothing. Okay, they feel hot all the time. And does that feel good? No, that's very irritating, correct? It's irritable, I mean you're sweaty. Yeah, your underarms are sweating, your hair's always wet. Okay, you're constantly drinking, craving for something to drink because you're sweating a lot. And you have diarrhea instead of constipation. Okay. Although they have increased libido, however, they will have problems conceiving because they have amenorrhea as well. Here, oligomenorrhea. Okay, so hard to conceive. You saw coarse, brittle hair in hypo, correct? Here there is fine hair. So in either case, in coarse, brittle hair weakens it, correct? So there's hair loss in hypo. So here, what about here? pretty much the same. This one just feels different. This one is fine hair, which weakens it again, and they still lose hair. So the cardiac effects are again very serious. So when they're admitted to the hospital, we have to monitor them, put them on telemetry, okay, to see cardiac function, cardiac rhythm, how are they doing, frequent blood pressure checks. But take note that they are very irritable. So what will that cause? What will that what effect will that have on their blood pressure and heart rate? It'll be even be higher. Okay. So if we had mixed edema in hypothyroidism, we also have something equivalent here. We call it a thyroid storm, which is a severe form of or severe state of hyperthyroidism. Patient can go into a stroke, a hemorrhagic stroke, or a heart attack. Management. There are many ways to treat hyperthyroidism. Let's start with drug activity. The drug options first. We have medications known as anti-thyroid medications. They are called methimazole. There's also an option to do surgery. There's also an option to use radiation. Okay, so 3 different ways to treat hyperthyroidism. Now, the choice as to which one will depend on the patient's age and certain conditions. Let's say if this patient is, what's the peak onset again? 20 to 40. So are these women of childbearing age? Yes. Again, there are some males who are afflicted, but again, majority is female. Okay, with thyroid problems, it's usually doesn't matter hypo or hyper, majority female. So if they're 20 to 40, so that means they're sexually active, right? Plus, what's the libido again with these patients? Increase, right? So most likely, can they get pregnant? So if they're pregnant, which option will be off the table? Radiation will be off the table. You understand? So we have to, the doctor will discuss with the patient, okay, depending, are you pregnant? Okay, or what's your sexual life like? Right? So they'll consider options. Okay? Because the methimazole, these anti-thyroid agents mentioned here, are teratogenic. So they can cross the placenta. Okay, so they have to switch, meaning the patient has to be on how many methods of birth control here, knowing that it's teratogenic, at least 2, right? So they can't just be on one because again, it's dangerous if they're on it and they get pregnant. Okay? We'll get to there's a table or a chart for the drugs. Now, the other drugs mentioned here, particularly the beta blockers, here beta adrenergic blocking agents, propranolol, atenolol, metoprolol, is not for the thyroid. It's really for the heart rate and the blood pressure. Okay, remember, these patients are hypertensive and tachycardic. Okay, so that will help with the, because they're shaky, they have tremors because of the tachycardia, and they feel nervous. So that is for that symptom. All right. Okay, so let's go to each one. Let's start with the drugs first. So we've got radiation and anti-thyroid medications. For radiation, this is the use of radioactive iodine. So you swallow radioactive iodine. RAI 131. There's a RAI 129, which is a slightly slower, lower radiation, but that's only used for a thyroid scan, to diagnose thyroid cancer or hyperthyroidism. But that's for testing though, so that has a short half-life. RAI 131 has a longer half-life. So this is used for treating hyperthyroidism. Okay, as mentioned, it's contraindicated in pregnancy. Therefore, what should be done before initiating this therapy? Okay, we have to see whether you're pregnant or not. If once we establish you're not pregnant, what do? Make sure you stay that way. Okay, we can't have you pregnant while you're receiving radiation. So you will be placed on birth control. Okay, 2 forms to make sure we have a backup. Breastfeeding is also contraindicated, indicated. I mean, for obvious reasons, right? If the patient is breastfeeding. So the radiation here will be absorbed by the thyroid glands. Now, it's generally safe because what's the only organ in the body that uses iodine? Only the thyroid gland. No other organ in the body uses iodine. So therefore, if you swallow the radioactive iodine, where will it go? Into the thyroid gland, destroying it. All right. So what's the effect of this therapy? What will the end result be? Destruction of the thyroid gland, and what will you develop? Hypothyroidism. Okay, so patient must understand, yeah, we have to destroy this. And however, at the end, you're gonna have hypothyroidism. And how do we treat that again? Lifelong levothyroxine therapy. Yes. It's okay. I'm here all semester. Unless I die or get fired. Okay. Now, warning for radioactive iodine therapy is remember, what is the function of iodine and what is its effect on the thyroid gland? It's going to stimulate the production of T3, T4, right? Okay. So therefore, what was one of the causes listed in the chart under hypothyroidism? Deficiency of iodine intake, right? Meaning patient has little to no iodine. What was one of the causes listed here? Too much iodine intake. Now, if they're already in hyperthyroidism and you give them iodine, regardless if it's radioactive or not, what will it trigger? Even more T3, T4 production. So can this trigger a thyroid storm?
Yes.
Yes. We'll get to the manifestations and signs and symptoms of thyroid storm later. But don't worry, we have we'll get to the um, nursing responsibilities. Okay, so we will have to give something before we administer radioactive iodine. Are we clear? All right, so we'll get to that later. So here, look at this paragraph. Thyroid hormone replacement is started 4 to 18 weeks after anti-thyroid medications, including radioactive iodine. So after you stop it, we have to start replacing already because we know the end result, right? The thyroid glands will be destroyed and therefore you will become hypothyroid now. But please make sure that the patient understands again. So it takes a while, okay, for these things to work. And a warning also, during radioactive iodine therapy, is this radiation? Yes. Is this external or internal radiation? This is internal. The patient swallowed the thyroid, the radioactive iodine. So can it enter body fluids? Yes. So the patient's saliva, urine, feces, reproductive secretions, are they radioactive? Yes. Say for about 2 weeks, okay, 2 to 4 weeks, the patient must exercise care with these body fluids. Yes, abstinence also, because I mean, is there really any way you can, even if you wear a condom, right? There is still radiation because that's close contact, correct? All right. So make sure the patient understands, that they don't share utensils, they don't, how sometimes we with our children we share with the same spoon, right? So just make sure you be careful, right? And when they use the toilet, what do they do? I mean, you don't have not everybody has their own toilet, right? I mean, we share it with our family. Okay, make sure you flush it twice. Okay. Also the washing machine, because you may have some, some skid marks in your underwear, right? And there's radioactive, those are radioactive skid marks, right? So you can't be washing your children's clothes together with those skid marks, all right? So make sure you wash them separately. You understand? I mean, these are practical considerations, right? Okay. I mean, they don't put that in the textbook, okay? But I mean, there are skid marks, right? Yeah, Maria has, yeah.
But it makes you think about yeah, that's fine.
Wow, yeah. Anyway, oh, have you ever seen fart come out of the butt, like up close?
What?
Have you ever seen it?
How?
No, I have. Like, like changing a patient.
Did you get?
No, no, no. I mean, I know where to position, but there's a mist that comes out. A mist, yeah. So that's why it does cause a skid mark, because the mist, of course, that's moisture, right? Yeah, and then it get caught in the cloth fibers.
You got a cock
So yes. Don't believe me. Watch for yourselves.
Wait till they happen.
All right, so let's look at thyroid storm. Again, this is life-threatening. So this is equivalent to, or this is the counterpart of myxedema, right? So this is also life-threatening. Let's start with the manifestation. So how do you know your patient is going into thyroid storm? Let's look at the trigger first. So what would cause a hyperthyroid patient to go into a thyroid storm? Anything stressful. Okay, so any crisis, anything that will aggravate the patient's symptoms. So can it be physical? Can it be an illness? Can it be surgery? Can it be some emotional event? Yes, doesn't matter though if it's a happy emotional event or a sad emotional event. Makes no difference, because what happens to your heart rate? Increases either way, right? You won the lottery, or you heard someone died, same effect. It increases your heart rate, so it triggers thyroid storm. So anything good and bad that excites the patient causes or triggers a thyroid storm. These are your manifestations. Now, first one on the list is what? The body temperature. An increase of even 1 degree, right? Now, it doesn't have to be fever, because let's say my baseline temperature is 97. When it reaches 98, is that abnormal? Is that, no, it's not abnormal. However, if you have hyperthyroidism, is that concerning? Yes, that could be a thyroid storm sign already, right? And then next would be the increase in heart rate, blood pressure, and then what are the symptoms of increased blood pressure? No, although hypertension has no symptoms, right? Generally, but if you have severe hypertension, what are those symptoms now? You have a headache. What else? Dizziness, nausea, vomiting, okay, diaphoresis. So those are the manifestations of severe hypertension. And then, of course, there are some altered mental states now, delirium, psychosis, or the patient also goes into a coma here. Yeah, very. All right, so how do you manage it? First is, again, what's the first thing you can do here? You suspect thyroid storm in its early, hopefully you caught it early. So what's the first action? Is it a code? Is this patient pulseless and breathless? Call the provider, right? So call the provider, call RRT. You suspect. Here are again the triggers. Okay, so it could be anything, right? Anything stressful. So here's your management. So after notifying the physician, these are your interventions. So the temperature will be managed with, of course, cooling blankets, give him oxygen to improve circulation to the brain, ibidextrose. These two drugs here, PTU, polypropylthiouracil, or methimazole. These are the two thionamides. We will get to them separately later. Hydrocortisone here is given to treat shock or adrenal insufficiency. Now the iodine here, this is large dose iodine, okay? Now, the idea behind giving iodine is to, if you give it in large doses, it will actually suppress thyroid activity. This is how it works. Same idea as, let's say you're at the buffet, somewhere. Let's say you went to the buffet. After, let's say, 4 or 5 trips to the buffet, someone offers you another plate. What will you do? I'll say, let's say 10 trips to the buffet table. You go like that. Oh, no more, no more. Why did you say no? You paid for the whole thing. Why are you stopping now? Too much, right? No more. Same idea here. If you flood, the iodine here is in the form of SSKI, saturated solution of potassium iodide, SSKI. It's potassium iodide in large dose. So the effect of this oral preparation is actually to suppress thyroid activity. So just like the buffet is, no more. It's too much iodine at one time. It will suppress thyroid activity. Are we clear? All right. Now, however, because it is iodine, will it nonetheless make the thyroid storm worse? Actually, yes, it has the potential to do that. So therefore, the protocol is, let's go to the antithyroid medication. Before giving any iodine preparation, including radioactive iodine, you should give an antithyroid medication first. So you either give methimazole or propylthiouracil, or the acronym for this is, the short is PTU. So these are your antithyroid medications. So let's go to this table 45-1 right here. So these two drugs, look at the action. Read the action for me. For PTU. Okay, so blocks synthesis of hormones, whereas methimazole inhibits what? Okay, therefore, if you give this and then you give iodine, will the iodine enter the thyroid gland? No, because you gave the PTU or the methimazole first. Look at the action. They block, right? They block thyroid hormone activity. So therefore, can iodine bind in the thyroid gland? No. So what's the sequence here of the medication? Give this first, and then you give the iodine. So which is not it doesn't contradict this chart, because look at what was given first. So the blanket, the oxygen, IV fluids, PTU or methimazole, and then the iodine. Make sense? Okay, so always the time duration, by the way, is 1 hour. Okay, so you give PTU or methimazole 1 hour prior, and then 1 hour after giving it, then you can give the iodine. Are we clear? All right. Another, let's go to the last. Please read the nursing responsibilities here and read the paragraph, because these drugs again are teratogenic, remember? So they cross the placenta, and watch the side effects here. So there are many options for the iodine preparations here. We have sodium iodide, potassium iodide, or SSKI. We have 3 oral iodine preparations here. Regardless, what should you do when you give it? Methimazole or PTU first, and then 1 hour later, you can give the iodine, okay? And what here are other considerations. Mix it with juice or milk. Why? This is iodine. So, okay, you're gonna have really brown teeth. Okay, unless you like it like that, then go ahead and swish it around. Okay, but it will stain your teeth. Okay, imagine you've seen betadine, right? Yeah, go ahead and paint your teeth with betadine. It'll turn brown. So give it through a straw mixed with juice or milk. And beta blocker, what's the purpose again of giving this? Okay, this has nothing to do with iodine at all. This is simply symptomatic management. All right. So for surgery now, let's say the patient wasn't uh, cured by medication or radiation. Now the surgery is the decided option. All right. Before we do surgery, remember the patient is in a hyperthyroid state, correct? They have goiter. That means what is the why is the goiter in, I mean why are is the thyroid gland enlarged? Increased blood flow, correct? Yeah, very high blood flow. So what will happen if we cut the patient will bleed, right? Bleed to death on the table. We can't stop it. So therefore, what should we do before we schedule surgery? So the objective is shrink the thyroid gland first. How do we shrink it? What was the medication again that will inhibit its activity? Iodine and the thionamides, that PTU and the methimazole. So we have to treat them with those first for about 2 weeks minimum. Then once the thyroid gland is, small, almost normal in size, then we can schedule the surgery. Antithyroid, yeah, PTU or methimazole, not both, okay? Or, so either PTU or methimazole. Yes, they have slightly different actions, but in the end is they block thyroid activity. Yeah, for 2 weeks prior. Yes. Can't hear you, dear. Biphosphonates. That's for osteoporosis, remember? No, that's for to strengthen your bone. Yeah, but calcitonin decreases calcium level. Well, you don't have calcitonin anymore when you take this out.
Oh.
Yeah, so meaning you somehow no, the textbook never mentions anything about increased calcitonin. So it just talks about T3, T4 increase. So somehow it doesn't increase calcitonin secretion. The reason for that is calcitonin release is controlled by serum calcium levels. No. Okay, so the surgical removal here is, it could be subtotal or radical, meaning we remove the whole thyroid gland. The side effect would be related to, there are 4 parathyroid glands attached to the thyroid gland. So on the back, there's 2 on each side. They're attached to the thyroid gland, meaning they take their blood, they're like a dot size. The parathyroid glands are so tiny. They're like dots, okay? So you can't really tell them apart. So just embedded there in the thyroid gland. So therefore, if you remove the thyroid gland, can you separate the parathyroid? Impossible. So removing the thyroid gland means you remove the parathyroid as well. So it depends how much of the thyroid gland was removed. Is it the entire or did you leave some? After the surgery, normal function should be back to 4 to 6 weeks if you had a subtotal. But again, if it's radical, meaning you took out the entire thyroid gland, then what did you develop? Hypothyroidism now. Are we clear? Again, but it should be okay. So calcitonin, it's fine.
No, even though
No, because no, radical, of course, you have hypoparathyroidism as well because you lost the parathyroid. But for subtotal, you have 1 or 2 parathyroid glands remaining. Okay. We'll discuss the parathyroid problems next week. We won't have time. Okay, so let's go. We know how to prepare. Let's now talk about post-op. So after surgery, so we already discussed what they're going to take. So we're going to give the iodine preparations and the antithyroid, right? At least 2 weeks before surgery, and then that will shrink the thyroid gland, and then we can schedule the surgery. So here, before surgery, an antithyroid medication is given until signs of hyperthyroidism have disappeared. Beta blockers are given to control the heart rate and other symptoms. Okay, we stop anything that will cause bleeding, anticoagulants or aspirin. All right. And here, if they did receive iodine preparation, make sure they did not develop thyroid storm. Okay. So let's look at the surgery. Where is the thyroid gland? In the neck, right? Right here. So therefore, when you slice it here and retract the tissues, exposing it, and then you clamp the blood vessels, and then you take it out. Okay. What could happen after surgery? Give me 3 possible problems. The incision is right here. Airway first, okay? So airway. Could there be airway compromise? Okay, so watch for lung sounds, respiratory effort. Watch that. Could there be bleeding? Okay. And then, although, regardless if it's radical or subtotal, with radical, definitely we don't have parathyroid glands anymore, correct? 0. All 4 are gone. If it's subtotal, even though you left some, 1 or 2 parathyroid glands, however, were they injured? Yes, they were injured during the surgery, okay? So therefore, there's only one function of the parathyroid hormone produced by those 4 parathyroid glands, which is what? To increase serum calcium levels, opposite calcitonin. So therefore, without the parathyroid hormones, what happens to the patient's calcium levels in the blood? Will it drop slowly or suddenly? It will suddenly drop. So what would you monitor for after the surgery? Signs and symptoms of hypocalcemia. So what are those signs again? You learned in fundamentals? And okay, so those would be, of course, there are other manifestations. Again, we'll discuss those next week. We have no more time tonight. Yeah, so airway, watch for bleeding, and finally, signs of hypocalcemia. So what should you have at the bedside? Let's say it's an airway problem. And suction and what if I can't put an airway? Okay, tracheostomy tray. Okay, just in case you have it ready. Now take note, the patient's position here, will they be flat on bed? They will be or semi, okay? Fowlers or semi-fowlers. So if I'm like this and the incision's here and I have a pressure dressing here, where will the blood go? If it does bleed, will it run down here or run down the back? It will run down the back, okay? So make sure you're not just watching here. Check the patient's back, okay? The sheets, the gown in the back. Check for bleeding there, right? Because it's a unique position. We typically don't have patients laying like that because of that position. Yeah, it's good. We can see it if it's bleeding here, right? What if it's bleeding here by gravity? It bleeds toward the back, so check the back periodically. That's it for today. So that's the only quiz next week.